Thank you for joining us. I have Dr. Vishtasb Ariazand, who is a breast radiologist, and we're going to be talking about breast imaging. Thank you for joining us.
Thank you for having me.
Okay, so breast imaging, there's a variety of different ways that we can look at that. Give me an example of some different kinds of imaging.
Well, basically, what we do is very methodical. So there's mammograms, which uses x-rays to look at the breast. There's ultrasound, which uses sound waves to look at the breast. And then MRI, which uses radio frequencies to look at the breast. And there's other ways to look at the breast which are not as common with nuclear medicine and things like that. But primarily, we start off with a breast mammogram as a screening tool. And then if anything's abnormal, we'll ask the patient to come back. We'll get more mammographic views and then typically add an ultrasound. And then from there is when we'll decide, do we need to stop imaging and do biopsies, or just follow it up with that kind of imaging, or do we need to add MRI as an extra tool?
So when you use ultrasound, how is that making it deeper for you to be able to view, or why would you go that route?
It's just a different way to look at the same tissue.
Okay.
So mammograms are very good at finding tiny, tiny calcifications.
Okay.
Calcifications can be early signs of breast cancer. Sometimes it's even pre-breast cancer that starts off at tiny calcifications. Unfortunately, ultrasound can't pick up that fine detail. MRI sometimes can't find precancerous lesions. So that's why we start with mammography to try to find those calcifications.
Okay.
And then when it comes to ultrasound, it is a useful tool because sometimes some patients have very dense breasts. And the mammogram will not be able to find certain cancers because breast tissue shows up as white. And then cancer shows up as white. And if you put white on white, guess what?
Exactly.
You get white. So that's where ultrasound can be used as a tool to look at the tissue with a different technology and try to find potential cancers underneath.
In regards to density, there are many women who have breast implants. How do you guys deal with that?
So breast implants, it basically makes us take extra images of the breast.
Okay.
So what we do is you take one set of images with the implants in the view, and then another set of images with the implants pushed out of view.
Oh, wow.
And typically when you push the breast implant out of the view, you are able to see the vast majority of the breast.
Okay, so you don't have to go to a different method.
Correct.
Okay.
Correct. Unfortunately, depending on where the implant is placed, it will dictate how much of the breast tissue you can see. Because they can place the implant in front of the pectoral muscle, or they can place the implant behind the pectoral muscle.
Okay.
If it's behind the pectoral muscle, that's when we're able to see the majority of the breast tissue.
Oh, okay. Okay, good. And then also, the way that they put the implant in, either in front or behind the muscle, how does that affect it?
So women who have breast implants are at a slight disadvantage to other women because the implant can obscure or cover up certain findings. So if the implant is placed in front of the pectoral muscle, that's where we can run into that problem.
Okay.
If the implant is placed underneath the muscle, then you're able to see the vast majority of the breast tissue.
Okay, so at least it's nice to know that you guys can address that without
Correct.
them having a totally separate type of screening.
Correct.
Okay, good. Let's talk about where in the breast is the most common forms of where cancer develops.
Good question. Breast cancer actually happens in the whole breast, anywhere as possible. We break it up into quadrants. So we describe it as an upper outer, upper inner, lower outer quadrant. The vast majority of breast tissue happens to be in the upper outer quadrant. So statistically, wherever the more breast tissue is located, that's where you're going to be able to find more cancers.
And then we have been talking about different invasive versus non-invasive breast cancers. So how does that differ?
So on our side, we can basically tell, is there something suspicious? Is there something not suspicious? Sometimes we can see a mass that's extremely suspicious because of some of its features, and we can assume that it has invasive components to it.
Okay.
But assumptions aren't going to help. That's why we do the biopsy. We send that tissue out to the pathologist So fellowship trained doctors will look at it under a microscope and they tell us, okay, these cells have now penetrated through the basement membrane, which is the boundary of the cell, and have now invaded out of the cell, and they get labeled as invasive disease.
Okay. Prior to any of this going on, any of the screening, when we're in our doctor's offices, is there any other type of testing that can be done prior to ever having a mammogram, like maybe some sort of genetic testing, or is that done after?
It all depends. And it really depends on how much information you have about your family history.
Okay.
So if you have a family member who had breast cancer, and the people who are going to have the greatest weight would be your mother, your sister, or your daughter.
Okay.
If they have a history of breast cancer, and let's say they had it at age 38, if a mother had it, then the daughter should start imaging at age 28.
Okay.
So at a 28-year-old, it gets kind of complicated, but we would typically start with ultrasound imaging until they reach the age of 30. Then we would start screening mammogram on that patient, and it's even indicated that they're going to get MRIs every year.
Right.
So it depends on knowing the family history, which would help push you to start sooner. And yes, genetic testing would be important for that patient. So all these tools will come together.
You know, something I find kind of difficult, over the years that I've been going to the doctor, is that I can't remember when somebody has had something. So should we know this history ahead of time before we even go to the doctor, or what do we need to do?
It's tough, and it all really depends on how close you are to your family.
Right.
And how comfortable your family members are with disclosing health concerns.
Right.
Typically with cancer or the C word, a lot of people will be open with that, or you saw them go through treatment. So that's how you can kind of get that information.
Okay. And how concerned do we need to be if, let's say, my grandmother passed away from colon cancer? Do I need to be worried about getting that particular cancer or any cancer?
It depends. Some cancers do run in families, some cancers do not. And it's hard to say because, for example, with breast cancer, I've noticed that the population will tell me, oh, you know what, I don't have breast cancer in my family, so I should be okay. But that's a fallacy. It's not true. Most breast cancer is spontaneous, and there is no family history of it.
Okay. All right. And at what particular age do we need to be concerned about getting any type of screening or being concerned about getting breast cancer or any type of cancer?
For breast cancer screening, we go off of data from research that we've had. And the American College of Radiology, which is our governing body, recommends starting at age 40 if you're at average risk. And again, average risk means no real family history of breast cancer, which may cause you to start sooner.
But we're seeing cases that are even younger than that.
Absolutely.
So,
Absolutely.
So at what point do you decide?
That's the hard thing, because there's 24-year-olds who get breast cancer.
Right.
You know, there's patients in their 30s that get breast cancer, and unfortunately, those cases are when the patient comes in saying, "Oh, doc, I feel a lump. There's something abnormal in my breast. I don't feel right. My intuition tells me something's wrong."
Right.
And when we look at those patients, we find out if they do have cancer, unfortunately, they have more aggressive, higher grade cancers. And statistically, from what I've noticed, it's those patients that may lose the battle to breast cancer,
Right.
rather than a patient who finds out that they have breast cancer in their 60s, for example, or
Right.
50s.
Right. But then self-care is also really important too,
Absolutely.
right?
I mean, it's one of those things where I don't like to practice with the old school style of medicine of telling my patient what to do. I come in and I tell them, this is what I know, this is what I see, and this is what I recommend. You are, the master of your body. You get to choose what you want to do with that information. Sometimes some patients will use that information and move forward. Other times their choice is to not do it, and
Right.
that's fine with me.
Right.
It may not be ideal for their overall outcome, but it's a life choice.
Exactly. Exactly. Any last things you'd like to tell anybody about all the different types of screening?
Well, one thing, and I hope that I can try to do my part to try to teach the people in our community is getting your screening done starting at age 40, doing it every year. And one of the important things that we don't necessarily know is, as breast imagers, old images are gold. Having an old image and being able to compare it year to year will be the way that we can find subtle differences and find cancers at an earlier stage so that their treatment will be more successful.
Right. Now, how hard would it be for them to get those images?
Sometimes it's a challenge. You get patients who come in and say, oh, I don't know, I had it in Orange County. Well, Orange County is pretty big. You know that. And without knowing the facility, it's hard to track it. So I'll educate my patient. I'll say, do you remember the facility where it might be located? Do you remember the name of the doctor that wrote you the prescription? Because all doctors will get a copy of the report. It'll say where the facility was, and then once we get the patient's permission via signature, we can grab the images and load them into our system.
Okay, which is so much easier to do now because I think everything's pretty digital.
Correct.
Right, so at least within the last 10 or so years, that would be easier to find than something even before that.
Correct.
Okay, all right,
But
well, good.
part of the thing that becomes hard is manpower.
Yeah,
So you request something at a large institution, and they might be inundated with a lot of requests, so the images may not come back in a timely fashion.
right.
So that's when I tell my patients, you know what? Sometimes when you just show up at someone's front door and you ask for something, you're bound to get it fast.
Well, that's
So if they
really
go to the
nice.
imaging facility, they can get a disc with the
Right.
images quicker.
Wouldn't that be like the squeaky wheel?
Yeah.
Yeah, there you go. Thank you very much for the information.
Thank you.
All right. Thank you for joining us.